Very much. Good morning, everyone. It's a great privilege and honour to follow on from that tour de force from Graham. And it's really wonderful to see so many friends and colleagues and radicals, and also Mary and family in the audience. It's been a great privilege for me to have known Julian. And I was introduced as having taken over, if I can say that word, Julian's mantle as president of the Socialist Health Association. But what many of you may not know is that over 25 years ago, when I was doing my work on the Private Finance Initiative, and I was having stones thrown at me by government, by Parliament, they were also being thrown at me by the Socialist Health Association, who thought to disregard and denigrate my work. And on that basis, Julian actually resigned as president of the Socialist Health Association. So it's like coming full circle, the honour of being elected. Not that I have anything really to do. I'm like the Queen sitting there, like Julian was the king, really, or the president. Not that we believed in the monarchy either. You know what happens to kings and queens. And also, so everybody has stories of their encounters with Julian, so I'm not going to take up my talk with sentimentality, but also to say that I'm sure Julian had a hand in me being appointed to the Bevan Commission in Wales when I did the Julian Tudor Hart lecture in Cardiff. It was the very first one in the university. But again, I only lasted 2 years because they thought this woman is too radical for us, and it was dissolved and new appointments were made, and Professor Pollock was not on the new panel. But Julie and I had a lot of fun discussing what was going on and how to try and outwit the civil servants, actually, as it happened, who were busy trying to create and forge a different path from the one we would have wanted for a national health service in Wales. So that tells you a lot. As you've heard, Julian was a man of very many parts. He wasn't just a GP. He understood very well the importance of the system and the system that we work in. And we are only as good as the system that we work in. And there were so many things I wanted to talk about you today. My head is to talk to you about, but my head is exploding. But I do want to say one thing, and it touches on this: don't mourn for me, but organise. And I want to put a challenge out to you today about organising for rehabilitation services in Scotland. Because at this moment, my thoughts have been very much with my 90-year-old father, who is lying in a bed in Forth Valley Hospital, and who should not have been there. How many of you have heard of the cascade of dependency, or pajama paralysis? Well, cascade of dependency and pajama paralysis results from hospitalisation when older people are immobilised, do not receive enough physio, and actually also result in being catheterized. Because if you're catheterized, you're immobile, you're not taken to the toilet, you're not walked. And my father was admitted 5 weeks ago, 4 days after his 90th birthday. He'd had a severe hemiparesis 30 years earlier, and he was left lying on a bed for 5 days. In that time, he has now forgotten how to stand and to walk. So he was admitted completely mobile and completely continent. And despite all of my activities on Twitter to those upstairs, despite all my exhortations on the ward, he's having 5 to 10 minutes of active physio 3 times a week. He is never going to be able to walk again. And that was partly because he was admitted because he had a number of falls, but the GP, and it was a locum GP, but there was no continuity of care. They would have known to have put in that extra package of care that he needed. So at every point, the system has failed him, both in primary care and in acute care, and it's still continuing to fail him. And what I have discovered is that Forth Valley Hospital has not put in the rehabilitation services. The wards are simply holding places. They're holding pens. And actually, the consultants and the physios appear to be powerless. They've normalised the fact that there are no resources there anymore. So they've normalised 10 minutes of physio 3 times a week because they say it's bad for him to get over physically exerted. This is a man that could walk 5 weeks ago, that came in with no medical condition other than a breakdown in the social package of care. And I'm discovering that there is no rehabilitation for older people in Forth Valley of the kind we need, and that resources have been stripped out of the hospitals. I don't know whether they're in the GP services or community, but I would say this is my challenge to every one of you today, is that we need to do this much, much better for older people. This is not where I was intending to go with my talk, but it's in the top of my head, and I think Julian would approve, because he also was 91, so he knew what it was like to be vulnerable. So the WHO, as you all know, is all about alma ata and health for all. And Julian was the first to recognize that what we have is great waste. The maldistribution of resources results in enormous waste of people and people's lives. And these are the two challenges for primary healthcare that you face, many of you, every day in your surgeries. Things that you can't do anything about, the social determinants of health, income, housing, food, and public services. You may be able to give advice, you may be able to give welfare benefit support, direct people to food banks, but you actually can't materially affect that. That can only be done through the politicians. The other area of waste and maldistribution is the marketisation and increasing privatisation of our healthcare system, where the resources are flowing in the wrong direction. They're flowing to the wrong parts. Too much on medicines, screening programs, vaccines, not enough on the rehabilitation and the care and the people that provide that care. Just to remind us all, and Julian was very much part of this, the radical plan, the 5 giants, and the reminder to all our governments that the abolition of poverty before the war was easily within the economic resources. It was a needless scandal due to not taking the trouble to prevent it. And here are the 5 giants, and on the 25th of April, you're all invited to a conference on the 5 giants in human rights at Newcastle University that we're hosting, and it's free, 25th of April, put that down. It's a really important one because it brings together human rights and the 5 giants. And it came on the back of this visit from this man who came to Glasgow in November. How many of you saw him reported? Philip Alston from the US, the UN Special Rapporteur on Extreme Poverty. He did a devastating critique of extreme poverty in the US a year ago. A year later, he comes to the UK, and there's enormous coverage. And he is scathing about politicians not taking the trouble to care. 14 million people live in poverty, 1 in 5. 1 in 3 children are living below the poverty line. 1.5 million are destitute. They cannot afford housing, food, and basic essentials. And you trip over them all the time now, in the station, in the cities. In London, they're lined up in tents along the Strand. I'd never seen that phenomenon before. Rising numbers of homeless and 5 million people using food banks. We now know the government has finally admitted food banks and food poverty is an issue. And accompanying that has been the major cuts in expenditure in public services, social care and health care. Food banks are a disgusting phenomenon. They shouldn't exist. And here in Scotland, as you know, Jerry McCartney's report from Poverty and Income Inequality, 19% of children were in relative poverty. That's 180,000 children each year, many of whom you see in your practices. And that rises to 24%. 1 in 4, 230,000 after housing costs. And the poverty rates had been falling, and they're rising again. We should be rising up. In Scotland, in England, the situation is even more dire. I work in the northeast, where we've seen one of the major cuts in expenditure, 25% real-term cuts. How do you manage to provide services when you're going from 10 to 7.5 billion? The most deprived council cuts were 6 times more than the least deprived. So the northeast, we have almost nothing. 40% reduction in early help services, a 7% increase in crisis support spending, that's universal credits, which are having a devastating effect on people's lives. and 40% of council leaders unable to meet one or more statutory duties for children. It's absolutely appalling what's happening. Here, this red line shows a huge change for older people in expenditure on adult social care. Only adults with learning disabilities have seen an increase, but that's because of a shift of funding from the NHS to local authorities, so it's massaged. But look at these red lines: older people, physical disabilities, mental health needs, other adult services, extraordinary cuts year on year in adult social care. And you see that by the total number of receiving services have fallen by nearly 20 to 25%. That's that top red line. Everything has been falling. And that is at a time when we have got increasing numbers of older people. But older people are not the time bomb. We mustn't buy into that myth. Everything is affordable. There are no surprises here. We can do it if we've got the political will. And of course, as you've seen earlier from your presentation, the cuts in public services and benefit contribute to rising poverty and inequalities, reversing all our health gains. And it's a pity our politicians aren't in the audience today, both in Scotland and in England, because we can't let our politicians in Scotland off the hook either, though their funding comes tied through the Barnett formula and the block grant, as you know. And as you've all seen, it's all political, stupid. Those with the Scottish parliamentary constituencies, you can see, with very high life expectancy compared to those at the bottom end with low. I think we'll all go to Orkney, actually. Very nice place. I spent my summer holidays there last year. So I'm coming to Julian. Julian and the healthcare part of it. And we're always tempted. I always said to Julian, you know, after you've gone, Julian, they're only going to quote the first bit about inequalities. They'll never talk about market forces. And that's why we should never use only part of his quote. We must always put up the whole quote. And this is the second sentence. The inverse care law operates more completely where medical care is most exposed to market forces, and less so where such exposure is reduced. And somebody can put their hands up when I've only got 5 minutes to go, because I've probably run out. So, and he also talks about it as being a primitive and historically outdated form. I think this is very important, that we should never link the first bit without the second bit. Because there is no doubt there is enormous waste in our healthcare system. And it's even worse, if you think it's bad now in Scotland, it's worse in England where it's being dismantled. The effects of privatisation, marketisation, often concealed from view, increased costs and loss of coverage. And Bevan, and Julian was a great admirer of Bevan, and coming from the same part of the world, no society can call itself civilized if a sick person is denied medical aid, and he would have included rehabilitation, because of lack of means. We are no longer civilized. And the privatisation and the excess costs and the waste come from 3 different areas. And I'm only going to really talk about one, because I'm going to give you a little example of general practice, because you're trying to think about the future of general practice. The first is excess costs of the market in administration, interest rates, and profits. The second is a rapid introduction of medicines, technologies, and devices with insufficient evidence of efficacy and effectiveness, and it is getting worse. The accelerated medicines, we're seeing digital, we're seeing apps, it's all out of control. And the legislation cannot keep up with it and cannot keep it out. This tsunami of stuff and products that are being developed and researched by our own researchers. We're spending hundreds of millions, billions of pounds on IT and digital. And meanwhile, we're not spending billions of pounds on physio and rehab. But of course, the other thing about marketisation is risk selection. If you take nothing else away, remember that markets result in risk selection, pick and choose, denial of care, and the inequalities. Now, as you all know, the 4 pillars of the NHS were public funding, ownership, accountability, and provision, under the principles of equal access for equal need. But general practice, of course, was the exception. The vision of a salaried service under public ownership was abandoned from the outset, mainly because of the Treasury, the cost of buying out practice premises, and also because of opposition from GPs wishing to retain their autonomy and independent contractor status. And in some ways, that's actually been quite a good thing, especially, and Julian recognised that, in England, where the Health and Social Care Act, the independent status of the GP has been a last bulwark against privatisation. How ironic that that should happen. Many of you will know the history of the NHS, but I think of it in 2 periods. The GPs voted against, but 86% joined within a month. They could see what side their bread was buttered. You had the 50s Collins report on the state of general practice declining and this massive lack of capital investment because the Treasury really had a stranglehold. It was only about 2.5% of the GDP that was spent on the healthcare. Then 62 and 64 was a big moment. We had the hospital plan for new estates, we had the Gilly report, and we had doctors threatening to resign en masse. And finally, the Family Doctor Charter, or the Red Book, with the rules and regulations for how GPs were to be paid. From then, the government was in a mixture of investment, sometimes in health centres, but also public loan scheme for premises investment, because most people were operating out of their houses, as you know. But then we had the IMF crisis and the second phase, which is the shift to marketisation. First, enormous retrenchment and turning off the money. But many of you may know that the GP public loan scheme for investment in primary care facilities was privatised to Norwich Union. In 1990, we have the NHS and Community Care Act, the internal market, and the controversial GP fund holding. We had the Primary Care Act introducing PMS. We had the Carson report, changes to GP contract and out of hours. And then we had the big bang of the new GP contract that I'll come back to. Then we have the global financial crash where the money is turned off completely and the government has got full pelt in England, not in Scotland, but in England for dismantling the NHS with the Health and Social Care Act. And now the government, and I'll take you a little bit through what's happening in England, because the idea that Scotland can remain immune from what's happening in England is just a nonsense. Scotland has about 5 million people, but England, as you know, has 55 to 60 million people. So, of course, there's going to be a great flow of traffic. So the entry of the corporates come, and I met a lady from Liverpool, who's a lady from the Liverpool Health Centre today. She was telling me, you maybe speak later about it, but the new contract forms of GMS, PMS and APMS, which allowed the commercials and corporates to come in. And here are a few of our friendly commercial providers of primary health care. Many of them have hung up their keys when it hasn't made money, like United Health, that's Simon Stevens, the CEO of the NHS. He was formerly president of that. And of course, Virgin Healthcare. But there's a whole list of commercial providers. But things have not been good for primary health care. And just to show you this complicated, table, I've pressed the wrong one. General practice investment has fallen. I think it has fallen off the slide. But it's gone from about 10% to 7.5% over that period. What other interesting things are happening is that the list sizes are getting the population per practice sizes are getting bigger, and the number of GPs, both in Scotland and in practices, are shutting. So in England, they've closed 11% of GP practices have closed. That's quite a lot, and I don't know why it's doing this spontaneously. It's obviously telling me to get on with it. The other thing is the shocking decrease in the number of full-time GP practitioners. So you can see 32,000 in 2009. Yes, it is telling me to stop. Down to 28,000 in 2017. So huge reductions. And I tried to chart it. It's more difficult to see. But the The blue line is investment, which is falling. The yellow line is population per practice, which is increasing. The green line is the number of GP practices, which is decreasing and also decreasing sharply in Scotland. And the orange line is the number of FTE GP practitioners. They're not comparable, but the numbers are falling. So not a good scenario for general practice, despite all the promises that we have. So general practice in the government in England has now become the basis of the market in healthcare. The Health and Social Care Act removed the government's duty to provide universal healthcare, and GP practice lists have become a currency. They're trading at the moment in the marketplace. Because any provider, hospital or a GP, can now compete for the patients on the GP lists and all their resources. That is what's happening in England. So any hospital can actually set up a partnership and now begin to recruit patients. And the reason why they want patients is money follows the patient, both into GP practice, but also there are no longer area-based health boards or authorities. They are now membership-based. And we have moved in England to a membership-based system where people are selected on the basis of their membership. Have any of you been to London recently? If you have, you'll have seen the controversial, how many of you have heard of Babylon and GP at Hand? Which I think their practice has now grown from, 4,000 to 400,000? Huge in a matter of a couple of years. And guess, if you go to any underground, you can see GP at Hand adverts. And what's happening now is Babylon apps, they're now recruit this practice, and Hammersmith and Fulham is recruiting all the young people between the age of 24 and 38 or 40. They're recruiting them on, and they're disenrolling from their GP practices, causing instability to the GP practice, but also to what's called the clinical commissioning groups that buy the hospital care. So we've got enormous destabilisation, and the government has now, NHS England has given the go-ahead for this scheme to be rolled out to Birmingham as well, and that's before the evaluation has even finished. But on top, Babylon started off life as a GP app for private GP consultations, so it's now mixing private and public. The investors behind it are DeepMind people. The investors behind DeepMind, you remember with the patient data issues in Cambridge, Royal Free Hospital, and we've got Mr. Ali Parsa from the failed first franchise of an NHS hospital in Hinchingbrook, Cambridge. Don't think this isn't going to come your way. You are going to have to really scrutinise all the legislation and all the regulations if you're going to make sure you're going to be protected from the Ali Parsas and the GP Babylon. But look, as I talked to you about risk selection. Really important to know that GP at Hand has got loads of exclusion criteria. Women who are or may be pregnant, adults with a safeguarding need, people with complex mental health conditions, physical, psychological, social needs, people living with dementia, older people with conditions related to frailty, end-of-life care, and so on and so on. Because when you sign on to Babylon, what you don't realise is you're actually disenrolling from your GP practice. You're here. And also you're forfeiting your rights to home visits and a lot of other sorts of care. So here we have risk selection. The providers are selecting out the profitable, healthy patients and leaving the unprofitable, poor ones behind. So this is what's happening in Tower Hamlets, one of the most deprived in England. It suffered greatly from the change in the allocation formula, but also GP at Hand. So younger and fitter patients are now leaving the practices in London in their hordes and going to this big practice in Hammersmith, which is opening up branch surgeries all over London. This is affecting the risk pool, so you're left with the sicker and less healthy ones, but it's also affecting the equivalent of what should be the health board because the money flows across. So I can join GP at Hand, and I might live in one part of London, but all my money will flow to where that GP practice is a member of. And that is not necessarily where I live in Tower Hamlets, for example. So this is proving an absolute catastrophe. And in spite of a planned evaluation that hasn't been announced, the government is now rolling this out because they can do it. It's legal. It's in the Health and Social Care Act. The third piece of privatisation that's coming your way in primary care is estate strategy in private finance. What the government is planning on doing is rolling up all the money from primary care and giving billions of pounds of contracts and awarding them as single contracts. And it wants to create super practices or vertical integration where the hospitals and the practices merge. They no longer cover their area, no public health required anymore. It's a membership-based system, and you choose where you're going to go, like an insurance pool. And it's here in a way in Scotland, because what people don't realise is that all these new fancy buildings that you're getting in primary healthcare centres are being built under Hub. How many of you have heard of Hub in Scotland? Well, I advise that you read up about Hub. It's very like the equivalent of LIFT, the Local Improvement Finance Trust in England, because Hub is a public-private partnership, which is debt finance, where you get locked into contracts for 30 years, and it's ripping out the public sector. And what is, to me, is extraordinary, this is from Scotland, Ferret, the private finance. These are some of these new hubs that are going up in partnership with, libraries, schools, whatever. And it's all built through the PFI, private finance. You're entering into long-term debt repayments at extraordinary costs. And here are some of the beneficiaries, mainly companies outside of Scotland, not local companies. So you've got Morgan Sindall Investment there, and you've got the 5 big hubs here in this report. But the important thing is we're paying astronomical amounts. What's the interest rate at the moment? What's bank interest rate? Oh, come on, you must have investments. 0.5%, 0.75%? Yeah, 0.75%. So would you take a mortgage out if you were paying 10%? No, because your mortgages, you could get a mortgage, public loans board, for about 2.5%. This is what we're paying on the hubs. This is coming from Jim and Margaret Cuthbert's work. Okay, I can see people looking at their phone, and I'm coming to the end. But the point I'm making is that the money is leaking out of our health service and in to private investors like this, and the construction companies and the shareholders. And none of you in this room are aware of it. And that is why you're seeing this big decrease in general practice and in funding. And you need to get on top of this because there's more and more of it coming. And it gets worse because these payments are index linked, which means the money that you pay to the investors goes up every year, and meanwhile, the cash stays the same. So here's Margaret Chan, Director General of the WHO. I began with the WHO, and I'll end with her quote. Countries are realizing that a free market in healthcare with people buying and selling medical services like other commodities will never result in universal healthcare. In such a system, only the rich will receive adequate coverage, like Prince Philip, and the poor and vulnerable will be excluded. I wish my dad was Prince Philip. So, I'm going to remind you, end with Julian, and I've pulled it out because we must never put that quote up again in part. It should always be in full. And so thank you, Julian, and thank you, Mary, for all your support and all that we've had. And let's carry on the fight because that's what Julian would want us to do. So thanks for listening.